Venous thrombosis in children is very different to venous thrombosis in adults because most of the venous thrombosis we see in children happen in sick, hospitalised children. So the major precipitating factor, of course, is central venous lines, but other children who are sick in hospital with cancer having major surgery. So that changes two things. It changes the ability to anticoagulate the children, and it also changes the outcomes for the thrombosis. And so that's a really important difference to understand. The other really important difference to understand when we're treating children compared to adults is that when we're treating adults, we're just trying to fix what was broken. We're trying to make them like they were before they got sick. But for children, we're trying to ensure that their unlimited potential is there for the rest of their adult life. So it's a totally different paradigm of treatment as well. The ASH VTE treatment guidelines were first done in 2018, and since 2018 to now, there's been an explosion in the amount of trial data that is available in children, and that's predominantly because of the industry-sponsored DOAC trials that have taken place. Large trials of rivaroxaban, of dabigatran, and now of apixaban mean that we've now got more data on children who have been enrolled in clinical trials by a factor of 10 or more compared to what we had to inform the original guidelines that were written in 2018. So that was why they needed to be updated, A, because we had so much more data, and B, because the range of drugs that we could use in the children was different. So to keep the guidelines relevant to current practice, we need to be able to consider those things. So the first distinction to make is the difference between symptomatic DVT and clinically unsuspected DVT. So we're very comfortable that symptomatic DVT usually require treatment, whereas it's a lot less clear whether clinically unsuspected DVT in children require treatment. Then if we have provoked DVT, what we now know predominantly from the KIDS trial, which was completed recently, is that if you have a provoked DVT and at 6 weeks of treatment, that DVT is now resolved or has now become non-occlusive, that it is safe to stop treatment at 6 weeks and the children will do just as well as if you continued. However, the KIDS trial specifically excluded a population of children, so it's only in the specific children who do not have other risk factors, who do not have an underlying cancer, do not have a thrombophilia or antiphospholipid antibody, that is appropriate. All other provoked VTE in children should be treated for 3 months. For unprovoked VTE in children, we think they should be treated for at least 6 to 12 months. Clearly, in the adult phase, unprovoked VTE is treated indefinitely, but indefinite anticoagulation is very problematic for children. It has a huge impact on their quality of life, and it has a huge impact on their mental health. So our recommendation is that children with unprovoked VTE should be treated for at least 6 to 12 months, and then there should be a discussion with the family about the priorities of treatment, and then further decisions made according to the family's values and preferences.